Yeah, good evening, everyone. I am Dr. Sunil. I'm a transplant surgeon working in Bangalore, and my topic for today is NASH and liver transplantation. So, this is we did a transplant for somebody who was 160 kilos. This was done in 2021, and it has almost been 2 years now, and patient is doing fine. He was a 38-year-old male who had NASH-related cirrhosis. And then he came to us. He was in decompensation. We optimized him. He did not have any living donor in the family, and most of other people in the family also had NASH. So that's why he had to wait for a cadaveric liver. He waited for almost 6 months, and finally he was lucky to get a cadaveric liver. We had a lot of logistic challenges handling somebody who was 160 kilos and then getting a OT table, all the instruments, and it was very difficult surgery, but somehow we did it, and then patient recovered, is doing fine, almost now 2 years. When this is a surgery we did this year in March. This guy is a patient who is a 73-year-old NASH-related cirrhosis. He also had HCC, undergone TACE in 2022 October, and then he was listed for transplant. So he got liver, DDLT was done, and he recovered within 7 days, and he went home very happily. And it has been around 3 months now, and he's doing well. So these two patients, they just tell us the spectrum of the disease. At one side we have somebody who is super obese and landing up in cirrhosis and then undergoing transplant, and then we have somebody who is 70 plus and NASH-related cirrhosis, diabetic. He also had a cardiac comorbidity, underwent coronary angio and stenting couple of years back, and getting HCC, getting TACE done for the same, and then subsequently getting transplant done. So this is how it's become more common in our clinical practice to get patient with NASH, NASH cirrhosis, and NASH with HCC. So just what Dr. Mithun has already discussed, NAFLD accounts for almost 75% of the chronic liver disease in United States. We don't have actual Indian data, but we feel up to 50% maybe cirrhotic patients what we see as related to NASH. NAFLD, as I said, there are two varieties: non-alcoholic fatty liver, and then we have non-alcoholic steatohepatitis, what we call is NASH. Dr. Mithun already said that the fat content more than 5% is taken as significant. So when do we call as NASH? It's a histological diagnosis. The three pathognomic features on liver biopsy are ballooning, lobular inflammation, and steatosis. So just because you have fat in the liver doesn't mean that you have NASH. Apart from steatosis, the person also need to have ballooning and lobular inflammation to diagnose NASH. So these are a couple of slides. When we have around 5 to 25% hepatocyte involved by fat, we called it grade 1. Grade 2 is around 26 to 50%. Grade 3 is around 51 to 75%. And grade 4 is more than 75%. So this is more important for transplant surgeon, because we go and harvest organs from cadaveric donors, and then we are seeing more and more donors are also having fatty liver. And then depending on the centers, some centers accept liver fat up to 50% in cadaveric donor. There are some centers which don't accept if it is more than 30%. So if we find that liver is fatty, then we get a biopsy done and then get it reported. And then depending on center to center, depending on the amount of fat, you either accept or reject the liver. So it has a lot of implication. The histopathology has a lot of implication in cadaveric transplant. And transplant surgeon is also should be well trained to get a rough idea looking at the slides how much fat, because you may not have a experienced pathologist if you're going remotely for a harvesting organ, and you may not find the liver pathologist there. So you should have some confidence in seeing the slides and decide how much fat is there, whether you want to take it or don't want to take it. These are the special staining techniques which are being used. obviously we don't do it when we go for harvesting. So why so much NASH? No, why do we today have this talk on NASH? Because the patient who have NASH, they're at risk of end-stage liver disease, and they're also at risk of HCC, hepatocellular carcinoma. 20% of the patient with NASH will develop cirrhosis over next 20 to 30 years. And then if you have NASH, then you are at risk of HCC. So the risk of HCC increases by 7.7 fold. So this data came from USA. So if you have NASH, you are at risk for cirrhosis, and if you are also at risk of HCC. And without developing cirrhosis, you can directly land up in HCC. So that's why you have to be careful in taking care of your liver. So coming to iLivTouch, I think we most of us are using this, and then we use this to assess the fibrosis in a liver. So it has good correlation, and these are the curves which show that iLivTouch has also been used in patients who have fibrosis with underlying chronic hepatitis B, and there is very good correlation. These graphs, and then it's also a very good modality in patients with non-alcoholic fatty liver disease. So there are recent study which was published in Journal of Clinical and Translational Hepatology, and it says that LSN can correlate with liver inflammation. So most of the other previous modalities which are in use nowadays, they only tell you about fibrosis, but then there's a recent study which says that by using a iLivTouch machine, you can in fact diagnose liver necroinflammation. So this is first of I would say first non-invasive assessment which can tell you about inflammation. Otherwise, you need to depend on biopsy to diagnose inflammation. And then again the same, that this is something new which is still being studied. So if we get this validated, then probably iLivTouch can be a very good modality to also to diagnose the underlying inflammation. So coming to relation between NAFLD and liver transplantation. So as per NASH has been a faster growing indication for liver transplant in the last 20 years. With the availability of hepatitis B vaccine and good therapies for hepatitis C, the incidence and prevalence of hepatitis B and C is coming down drastically. And then advent of this, the epidemic of metabolic syndrome, we are having more and more patients of NASH and NAFLD. So that's why we are seeing more and more cirrhotic patients related to that. So as I said, it is also a common cause of HCC in most of the patient. So the incidence of NASH-related HCC has gone up by 137% in last 25 years, if you go by US data. So diabetes, like as Mithun sir already discussed, diabetes, obesity, and cardiovascular diseases are frequent in NAFLD and NASH. So you also have to be like whenever you see a patient of NASH cirrhosis, you have to keep this in mind, that patients will be obese. As I said, one of our patient was 160 kilos, and they will have diabetes, and they have some underlying silent cardiovascular diseases, if not obvious. Then we need to have a specific strategy dealing with all these comorbidities if they end up in liver transplantation, and it increases the risk of liver transplantation. So Dr. Mithun already discussed what are the most common association between NAFLD and other diseases. So how do we manage just before transplant? Like if I see a patient, if I list a patient for liver transplant, if he has diabetes, obviously in our multidisciplinary team, we have endocrinologist, but the other things, as a surgeon, I need to be very sure, like what I want is there should be a OGTT to diagnose diabetes mellitus. We have to they have a regular HbA1c. The good glycemic control has to be achieved, otherwise patient will end up in repeated infection, and then a proper evaluation of underlying liver disease. Secondly, nutritional status assessment. So every liver transplant patient who is listed for transplant will undergo a nutritional assessment just before transplant. But the other things in patients with NASH is like most of them are obese, and then we also have to give them reasonable exercise for controlling this obesity. We need to give them good diet, exercise, as I said, and then if needed, we can refer them for bariatric surgery, as Dr. Mithun already discussed. Then cardiovascular diseases, a proper cardiovascular risk assessment has to be done, starting from just a DSA or a echo. Some patients need coronary angiography. Like our protocol has been, if the patient has diabetes for more than 10 years, then we prefer to get a coronary angio apart from stress test or DSA or something. So the patient with NASH can also have underlying kidney dysfunction, and you have to assess his kidneys, the patient's kidneys, before transplantation. And then malignancies, obviously, Dr. Mithun said that in patients with diagnosed colonic malignancies, the fatty liver is pretty common. So obesity itself predisposes patients for many malignancies. So you have to thoroughly evaluate the patient and make sure that they don't have underlying malignancies, especially HCC or colonic cancer, etc. So what after transplantation? So after LT also, most of the patients are prone for perisurgical, like in post-operative surgical complications, especially infections. And then after transplantation, patients who have NASH related cirrhosis have increased incidence of malignancies and cardiac events. So we need to keep that in mind. And then there is a recent American study which was published in Clinical Gastroenterology and Hepatology in 2019, which says that a patient who undergoes transplant for a NASH-related cirrhosis has a lower 1-year survival compared to other patients because of cardiovascular or cerebrovascular diseases. We see patients who have recurrent or de novo NASH after transplantation, and then though the liver transplantation cures cirrhosis, but we need to keep in mind that the comorbidities like diabetes, kidney disease, cardiovascular disease, it continues even after transplantation, and then it can worsen also. So we need to keep them in mind. And the patients after transplantation, they receive immunosuppressants like steroids and TAC and all. So that will also induce metabolic syndrome in some patients. And then the transplanted liver can also end up becoming steatotic. So the study from Medanta group says that 53% of patients after LT will have a metabolic syndrome. So we need to keep this in mind. Just because you have done a transplant and given a new liver doesn't mean that the other comorbidities are going to disappear. So they will be at risk even after transplantation, and the new liver is also at risk to become steatotic. The other thing we need to remember is the patient who has HCC because of NASH-related cirrhosis. So the graft survival rate and patient survival rate are somewhat similar. So just because you have HCC, like the one case I presented, like 73-year-old who has undergone cirrhosis for HCC related indication of transplantation. So the survival are comparable. You have HCC, you don't have HCC, but the survival rates are comparable. And the post-transplant tumor rates are similar between patients who get a liver transplant for NASH or non-NASH related etiologies like alcohol, hepatitis B, and hepatitis C. So this is what our dietitians give it to the patients who have a NASH-related cirrhosis. This is a good diet plan which was published in JHEP in 2020. So this is what our dietitians follow. And then the cardiovascular risk assessment, most of them will have a thorough clinical examination, ABG, ECG, and then an echo. And then if there is any suspicion of pulmonary hypertension, they end up getting a right heart catheterization. And then if if most of things are normal, then we don't evaluate. But if anything is abnormal on echo or something, or if the patient is more than 50 years, or if he has more than 2 cardiovascular risk factors, then we get DSC. There is a positive DSC, then we get a coronary angio. If there is high suspicion and DSC is negative, then you get a coronary CT or a nuclear medicine scan of the heart. So this is what we follow. So it's very important. So most of the patients who have NASH cirrhosis will definitely have some underlying cardiac issues. So you have to thoroughly evaluate them and do a risk strategy. And if you have to optimize, if patient has a narrowing in LAD and then it needs urgent intervention, then if patient gives you time, then probably you have to place a stent and then transplant him later. And sometimes the patient cannot wait. Then there are case series in which they have done CABG along with transplantation. So always remember that there may be underlying heart problem which you need to evaluate thoroughly. Diabetes. So if your patient is diabetic after transplantation, you have to taper steroid as early as possible. And then also minimize the CNS, tacrolimus, because tacrolimus is diabetogenic. So you can add antimetabolites or mTOR inhibitors, and then continue oral medications, metformins, like all those things. And then whenever you are using anti-diabetic medicine, be aware that there are interaction between immunosuppressants and all these medicines. And then if oral medications are not enough, then you have to put them on insulin. You have no other choice. Obesity, even after transplant, they have to be very careful about their lifestyle, healthy diet, exercise. Then we currently don't have any data on pharmacological treatment for fatty liver after transplantation. And then there are some patients who will need a bariatric surgery after transplantation. And then probably after transplant, they can withstand surgery better. And then as Dr. Mithun sir said, there is also upcoming role of endoscopic bariatric therapy in these patients. So dyslipidemia, again, lifestyle modification is a first-line therapy in all these patients after transplantation. And then if the lifestyle modification doesn't work, you put them on statins. When you're putting them on statins, look for interactions, put them on fibrate if they're not tolerating statins, but statins can have, the patients can develop myopathy. So you need to remember that. And then some people say that omega-3 fatty acids are beneficial. The patient has isolated hypertriglyceridemia. So this is how we manage dyslipidemia in patients after liver transplantation. mTOR inhibitors, if you are using, they derange the lipid profile. So you also have to be aware of that thing. So arterial hypertension, pretty common after liver transplantation. It may be because of pre-existing metabolic syndrome or related to TAC. And then the drug of choice is calcium channel blockers. And then you can also use other ones. And then beta blocker also used. And cardiovascular diseases after transplantation, patient who are more than 55 years, who are male gender, diabetes, kidney failure, you have to closely monitor them for cardiac issues after transplantation. So if patient develops renal dysfunction, then the immunosuppressive minimization, like we call them as renal sparing techniques, renal sparing immunosuppression, you can use that. And just to make sure that the renal function, like preserve it as much as possible, don't allow it to worsen. So that's our goal. So in nutshell, like what kind of immunosuppressive strategies we use for NASH-related cirrhosis patients who undergo transplant is early discontinuation of cirrhosis, TAC minimization, US antimetabolites, and mTOR inhibitors.